Hello there, my name is Dr. James Stoxen, and I am here in Dubai lecturing at the second International Conference on Surgery and Medicine as the keynote speaker. The topic of my presentation is simply, what are the conservative options available to patients who have had failed thoracic outlet syndrome surgery? So basically, you have gone in for your surgery for thoracic outlet syndrome and you expected to have relief, or you expect it to be pain-free, and after the surgery you're the same or worse. And what I have done is I have written a book. It's currently available on Amazon. It is also a #1 international bestseller, and the title of the book is The Human Spring Approach to Thoracic Outlet Syndrome. The human spring approach to thoracic outlet syndrome is significant in that the majority of doctors and therapists evaluate and treat the body as a lever mechanism, integrated lever mechanism, when in fact the thoracic outlet is built on a spring engineering platform. So you have lever mechanism treatments that work on patients' levers like elbows or knees, but they don't work on body parts or areas of the body that are designed as spring mechanisms. There's a big difference, and the book will teach you all about that. Chapter 2 and 3 go into the human spring design, comparing to the lever mechanism design, and it will review for you all the spring mechanisms in your body and why you maybe not have improved from chronic pain, from a condition, because that area of your body you're trying to treat is based on or built or engineered as a spring system, and you're only getting lever system kind of treatments. So this is the book, and basically I'm going to outline for you what this chapter is all about. First of all, when I go into the chapter, I talk about, what happens when you've tried everything. You've tried physical therapy, massage, chiropractic care, and you're at a point where you can't take it anymore. You and your doctor have considered surgery. When does the doctor consider surgery, and when does the patient consider surgery is very different sometimes. There are actually 10 reasons that I outline in the book about when you would or your doctor would consider surgery, such as if you have a blood clot in your subclavian vein from the compression of your shoulder and your first rib elevating into the outlet and your shoulder falling down into the outlet. So the thoracic outlet is actually a tunnel. The floor of the tunnel is the ribs here, and the roof of the tunnel is the shoulder girdle and the collarbone, part of the shoulder girdle. So when that outlet is closed down, you'll learn about how that happens in chapter 1. Then either you're going to get the right treatment to open that outlet up and allow the safe passage of the blood vessels and nerves, or the conservative therapy has failed to help you to open the outlet, and then you're going to consider surgery. Clot formation or thrombosis, which is a blood clot in the subclavian vein, can be a pretty perilous situation, because if that blood clot releases, then you could end up with it moving into the heart and then the opposite side lung and lodging into your lung and then causing a pulmonary infarct. This will cause you to have very rapid breathing, and you can actually die from a pulmonary infarct. It's called a pulmonary embolism to a pulmonary infarct. Then there's Paget-Schroeder syndrome. I devote an entire chapter to Paget-Schroeder syndrome, which is basically what we just talked about. And then if you have a failed conservative approach to treating your thoracic outlet syndrome, because maybe you're using the lever mechanism treatments, then maybe you'll consider surgery. I wish you'd please read these chapters in my book before you consider surgery, because I think it'll enlighten you as to what is the optimum treatment for conservative treatment to avoid surgery. And if you've already had surgery already and you're not improved, well, there are some options available to you. I'm going to give you the options that are available in this book. Now, there are 3 different surgical approaches. Really, we outline 2 in the book, and I even give you some nice pictures of how the surgery works. This is called the supraclavicular approach, and then you have the other approach, which is the transaxillary approach, which comes in underneath the armpit. And that, with the transaxillary approach, you have the advantage of not having a scar after the surgery. With the supraclavicular approach, may be considered by your doctor, because the doctor can get in, to the veins and artery, the artery and vein, easier from the front than under the armpit, to repair veins or arteries that may be damaged or scar tissue around those blood vessels. So we go over those surgeries, as well as the tenectomy surgery, which is actually the surgical resection of the pectoralis minor muscle. The tenectomy is where you do a resection of the pectoralis minor right here, which attaches to the coracoid process of the shoulder and drives the shoulder down into the outlet. Unfortunately, that's not the only muscle that pulls your shoulder down into the outlet. You also have the subclavius muscle underneath the collarbone, and 2 muscles in the shoulder, in the front of the shoulder, which is the biceps short head muscle here, and the coracobrachialis. Those muscles lift your cell phone when you're looking at your cell phone, and pull your arm towards your chest, this coracobrachialis, to when you want to pull, like ladies, when you want to bring your purse close to you, when you're a little bit nervous, or if you're looking at your cell phone, you bring the phone up to your eyes, you have to use those muscles. So those are the surgery options that are available to you. And it goes over in detail which surgery is the best. Also, we also discuss the cervical rib resection. Now, cervical ribs are extra ribs that are in your body, that are at the top of the rib cage. So you have 12 ribs, you have 13. Or maybe you have a bit of a rib, not a full rib. There's all kinds of variables. Also, you can have an enlarged transverse process. These are genetic or congenital anomalies. Now, let me explain to you. If you have had these cervical ribs for 25 years, 30 years, and you have no pain, and then all of a sudden you get thoracic outlet syndrome, the symptoms, and you go to the doctor, you have an x-ray, and they say, oh, look at that, you have cervical ribs, but you lived, and that's the cause of your problem, but you lived for 20 years, 25 years without pain, and then you had them. So how could it be that those ribs are causing the pain when you've had them for so many years? It's unfortunate that patients choose to have surgery to remove those cervical ribs that are actually, not normal, but they're not abnormal if they don't cause a painful condition. And when in reality they are just fine, and you really have thoracic outlet syndrome just because, just like everyone else gets thoracic outlet syndrome. You just have some extra ribs. So that's something very important to consider. Now, we also go over the operating time, how long it takes for different types of surgery for thoracic outlet syndrome, like the neurogenic, which is affecting just the nerves and numbness and tingling in the hand, is shorter than the surgery for vascular thoracic outlet syndrome, which is affecting the vein or the artery. Also, how long will your hospital stay be on average? And what are the complications, the possible complications of the surgery? What could happen? Like, what if the brachial plexus is clipped a little, or you have a nerve that's cut, or if you have inflammation of the covering of your lung, or if you have the lymphatic duct that drains the lymph system into your arterial or venous system here at the base of your spine that can get cut too. So, who is the best surgeon for the surgery of thoracic outlet syndrome? Which surgeons are the best, and how do you find them? And does your insurance cover it? Those are very important considerations. Like I said before, there's very few surgeons that will do thoracic outlet syndrome surgery. And the doctors in the room that I was here at the lecture, they said they stay away from surgery for thoracic outlet syndrome because the outcomes were not good. That's why there is only a select few in the United States that really focus on do this surgery more frequently than others. You want someone with experience. All right, now, how do hospitals rate the outcomes of these surgeries? Because if you go to a hospital, you might want to ask the hospital, you know, what is the outcomes? What are your outcomes for these surgeries, and what can I kind of bank on for my results? Get a kind of a feel for the estimate of what you can expect from your surgery. Now, the way hospitals determine the success rate is different, but mainly it's based on excellent, which is very little or no pain, good, which means that the major symptoms are decreased or gone, and then fair means you still have major symptoms, but they're a little bit decreased or have some or most of the extra symptoms that are not the main symptoms decrease, and then the poor, which means that you have no improvement or you're worse. So if you think that still having major symptoms but a little decreased is a successful surgery, then you will consider the fair category as a successful surgery. Most patients don't consider the fair rating as a successful surgery. So if you are considering the fair category, usually most surgeries are a little more than 50% successful if you don't include the fair category. In the book we talk about that, so I don't want to make any quotes or claims here. I just want you to read the book and you'll know more about how to question or ask the right questions from your surgeon. Now, also, will you be pain-free after the surgery? Is it likely? Now, well, I'm going to tell you that most doctors that do surgery for thoracic outlet syndrome do not expect the patient to be completely pain-free after the surgery. They expect them to be improved. Honestly, if you go to a surgeon and you get surgery to remedy your thoracic outlet syndrome and you are pain-free, that's an amazing feat for your surgeon, because when you surgically remove a bone in the rib cage and the muscles that attach in the neck, you're actually creating an imbalance between the both sides and a weakness in that area, because these muscles support the neck, and also the rib cage is this is very important for the balance or the equilibrium balance of strength for your neck, which is a spring system, and your head, which is a mass. It's like a bowling ball. It's like a 9 to 12 pound bowling ball sitting on top of your integrated wiggly spring, and maintaining that equilibrium balance is extremely important to stay away from chronic pain. So when you have those muscles, the scalene muscles resected, and even in the chest area when you have the pectoralis minor resected, it creates an imbalance and a weakness in that area. And one time I had this one patient that came to me and she was talking about surgery for thoracic outlet syndrome. And she said, well, after you get the rib resected, if you want to have it put back in, do they have a plastic rib that they can put in? And the answer is no. Once you've had the surgery to surgically remove these muscles and the first rib, that's it. You are stuck. And you can't put the rib back in, and you can't put artificial muscles in, and it's just, you can't do it. Once you've done it, you're stuck with the results. And that's why you have to really think long and hard and really learn about thoracic outlet syndrome in great detail before you take that step. Now, also we go into when you can return to work. After you've had surgery for thoracic outlet syndrome, when can you return to work? And based on the studies that have been performed, what can you expect? Then there are some government studies about surgery for thoracic outlet syndrome that I quote in the book that you might want to read. Now, after you've gotten surgery for thoracic outlet syndrome, typically you're given narcotic painkillers because it's neck surgery. So, sometimes you'll be getting these opioids or painkillers to ease the pain because you'll be in pain. And how soon, if you start taking them, how soon can you end up being addicted to them? Studies have shown, government studies have shown that the very first day you take opioid painkillers, some people will become addicted to them the very first day. The likelihood of becoming addicted to opioid painkillers after only a week of taking them is higher than a day. And the likelihood of being addicted to opioid painkillers after taking them for a month is much higher. And then also, what are some of the other options that are available to you if you do not improve 100% to your expectations from the surgery? So when you get to surgery and you're not 100% and you still have a lot of pain, you can't keep taking opioid painkillers because you're going to develop a resistance to them. In other words, you have to keep taking more to get the same effect. And then what happens? If you take too many, and let's say you have a bad day and you have terrible pain, and then you go to sleep and you're trying to sleep and you're tossing and turning and you have this pain, and then you say, oh, I can't take it anymore, I have to sleep because I have to get up for work, and you take one more painkiller. That might be enough to put you over the edge for maybe overdose. And if you have even too much, you could end up not waking up in the morning. So there's a definite danger in taking these little pills because you've heard the stories of people that have taken them and they've ended up dying from the overdose, but they couldn't save themselves. They didn't have a warning, like they didn't have dizziness or blurred vision or nausea from taking them and then rush to the hospital to be treated for the overdose of these painkillers. They just were sleeping, and because their brain was numbed, they just didn't wake up in the morning. So you have to be very careful with these opioid painkillers. And then there's this spinal stimulator, which is the option to opioid painkillers, which is a surgically implanted, let's say this is the spinal cord, they surgically implant like a TENS unit that stimulates the spinal cord with electrical current, and in the process it starts to numb some of the pain to either allow you to take less opioid painkillers, or maybe get off them completely. Now, there's some complications to the surgery, there's some complications to having this apparatus attached to you because it's surgically implanted the TENS unit as well, and you have a remote control that you can vary the stimulation delivered to your spinal cord, so you can kind of gauge that. Now, the thing is that these little sensors can become dislodged. And also, let's say that if you have a work injury and you are told by your doctor and your lawyer that you have to settle the case, and then you get your lump sum payment, and then if you're not also allocated the insurance after you've made your settlement, you have to be very aware of the cost of maintaining this spinal stimulator, because it has to be looked after by doctors to make sure that it's attached properly and it works right. So the average cost is between $5,000 and $20,000 per year. So that's something to consider. And in fact, if you're considering a settlement with your lawyer on a work injury or auto accident case, don't forget to include the amount, approximately $5,000 plus or minus on average, or more per year, to take care of this things that go wrong with the spinal stimulator. So that's the chapter on surgery for thoracic outlet syndrome. And I want you to know that I'm very respectable of surgeons that do surgery for thoracic outlet syndrome. Like I said before, when I was in the room giving the keynote speech today at the conference on medicine and surgery in Dubai, the doctors were very nice to me and very interested in my talk, and they had told me up front they stay away from surgery for thoracic outlet syndrome because the outcomes are not as good as they'd like it, and they were, very, interested in my presentation today. So I'm going to just tell you, if you're a surgeon and you do surgery for thoracic outlet syndrome, I give you a lot of credit because, if you can get even some of the patients pain-free, you must be really, really talented. So with that, I'd like to thank you for coming to listen about my book. I hope you can get a copy. I hope you can read the book from front to back, the full teachings, and I spent a lot of time on it. And feel free to review the book. Call me, email me, tell me your comments on what you've read, and I hope it teaches you, and I hope it gives you better information to make the right, informed decisions on how to manage your thoracic outlet syndrome. Thank you very much.